crucial to achieving that high-level objective will be the contribution of hospitals and health services towards better well-being, which is the subject of our discussion. So let's focus a bit on that. As I mentioned, Ann-Lise Guisset has agreed to step in at the last minute to give us some of her reflections on the issue that confronts us this afternoon. Ann-Lise.
Thank you very much, and I have a difficult exercise now, but I will. My objective here is to reflect on what was just presented and to anchor into the following discussion. And what I will try to describe here is how you can indeed consider hospital as an integral part of universal health coverage. This is what we discussed yesterday. But hospitals are not only health actors; they are also economic actors. And this is what we have heard about in the previous session. And they are also social actors. And this is really the point in this conversation. Why do I say this? I say this because we can view hospital as a place where we deliver care. We can see hospital as a place where people have their major experience in their life. This is where people are born, where people die, where people undergo vital surgery. So when I say that hospitals have a vital role in people's life, it's not just a vital, it's really vital. It's really a question of birth and death. So that's why probably hospitals have such a symbolic importance. Hospitals are a place, having a hospital in your neighborhood, this is something extremely reassuring. You know that if anything happens to you, to your children, to your parents, you have a place where, so it gives a sense of security for the community. And this is probably why it is so difficult if you want to close a hospital. If any one of you has tried closing a hospital, you know what it impacts and what it reflects. So it is a source of pride. It is also a source of fear. And it has a strong political component. So it's not technical solutions that we're talking about here, but really political aspects. This is why also it's so difficult. We see so many hospitals still being built, so many hospitals being asked by the communities. And this brings me to highlight that this creates such expectations, such trust, create also a strong social contract. And I was in a country, in a small district hospital, and the health worker said, you know, this country is really going really badly. There is no trust anymore in people. Everything is going back. And the last example is now that they are even not respecting any more hospitals. And she was telling me that the fact that some people came to steal the copper wire, if you go and do this in a hospital, it means you don't respect. You can attack anything, but not the hospitals. So this sense, this social contract is very strong, but gives also huge social responsibility for hospitals to be meeting those stakes. And that's why hospitals are indeed a place where care is provided, need to be centered around people's needs. Hospitals have a key element in structuring and supporting a well-functioning health services or health system for UHC, but also hospitals should lead by examples. They should lead by example. We expect them to lead by example in how they treat their staff, in their employment policies. They are major actor for gender equality. Many of their staff are women, and they are a key employer for women in the local communities. They should lead by example with regards to environment. How are they green hospitals? How do they have public work with public transport in order to ensure people can come with public transport? And those examples, how are they energy efficient? So this is, and they have also a responsibility to look at population health, to plan according to population health, to plan not as hospitals but as integrated service delivery networks. we should probably not talk about hospital, but talk about integrated services. But for those political reasons, this is what matters to people. So let's use this as an anchor to get to our work on integrated health services. This is why also, and for those reasons that Ms. Muscat highlighted on the need to go get the most vulnerable, we cannot wait for the people to enter our door as a hospital. We need to go and ensure that those who require services get to our door. So it might mean going to outreach or work with the primary care to ensure that those who need it have actually the services. But I will go even further. It's not about waiting for the sick patients to enter your door. It's really about how the community, the healthy people, enters your door and how you go outside your wall. So how the community enters your door, you could imagine that we see that there are some painting exhibitions, some concerts, so it's really building on this social role of the hospital to go much further. I will say this will be especially important in the rural areas. In many of your country, rural hospitals are striving for their survival. So it becomes somehow places with less specialized care, lower quality care, and the whole agenda around closing hospital beds in those areas is about quality. If you don't have enough volume, you don't have enough quality. But can we rethink the role of hospitals in those rural areas, building on their legacy, building on the trust, building on the relationship with the community, to have them play a social role, to have them adapt to the new needs of the population, being aging population? How can hospital become a place where, for instance, you have daycare for aging population, where you have rehabilitative care, where you have a number of other activities? And rethinking their role, thinking differently as part of the social system, will help them survive, not being just less good as the big hospitals in the city. And then finally, I want to highlight the role of hospital as a place for training and research. And we have here the Deputy Minister of Health on Education. I'm sure you will expand on this, but this is critical because the hospital of today are creating the healthcare and the health of the future. I think this is the topic of next year IHF conference in Barcelona, and I was very pleased to read this. So thank you for this opportunity.
Ann-Lise, thank you very much indeed. Great insights. In future, you don't really need to prepare for any conference you speak at. Obviously, given short notice, you're able to do it without any preparation at all. So thank you very much. I think you were reflecting on a new future for hospitals, this issue of social responsibility, a new view of role, a wider role, a revolution in a way, in perspective and activity. So let's now hear from Dr. Shu-Ti Chiou, Global Vice President at the International Union of Health Promotion and Education. Dr. Chiou is going to consider the role of health professionals. So absolutely critical, obviously. How do health professionals affect the social determinants of health? Dr. Chiou.
Yes, thank you. May I have my slides, please? I would like to thank the organizer and IHF for the invitation. It's an honor and pleasure to be in this beautiful country, this beautiful city, friendly people, and this very forward-looking visionary conference. And I'm going to talk about the role of health professionals in addressing social determinants of health. And in this morning, speakers have mentioned that social determinants of health is a very, very important determinant of health. It's about gender, ethnicity, education, employment, income, geographic location, housing, etc. And in the US, it's estimated that 1/3 of total deaths can be attributed to poor social conditions. And worldwide, even after controlling the contribution from smoking, physical inactivity, etc., still, low social rank independently increased 26% of risk of mortality, and it accounted for 90% of deaths for men and 15% of deaths for women. And the health gap from social determinants is still increasing in many countries, including those most developed countries. For example, in UK, the childhood obesity prevalence is higher in most deprived communities, and it continues to rise in the most deprived communities, though the prevalence in the least deprived communities has remained stable. And in Japan, the health variations between its administrative regions continue to rise in the past 10 years. And so yes, people with low socioeconomic status tend to be sicker, and the lack of appropriate healthcare accessibility exacerbates health inequality. However, healthcare system cannot be sustainable without tackling the upstream issue. You have limited resources and budget, and if the problems continue to grow, how are we going to manage the problem? So, how to tackle SDH and reduce health inequalities? The first thing to do still is to work on upstream approach towards a fair world. And what does it have to do with you? As have been mentioned, you are the experts, and people, especially decision makers, count on you. They ask you, how should we improve the health of our people? And if we say, oh, give us more budget, more money, we are going to solve all the problems. No, that's not the right answer. Please tell them to work on the 2030 Agenda of Sustainable Development on the 17 SDGs. And that's very important to build a fairer world. We have to treat the sick society, which made so many people sick, so that we can prevent health inequalities at the root cause of the problem. And the WHO has done the review regarding key policy actions which are powerful and effective to tackle SDH at the upstream. And they can be grouped into 4 or 5 areas beyond the health system. For example, to work on early childhood development and education, to work on access to fair employment and decent working conditions, and to provide social protection through social cash transfer to ensure healthy living conditions, and to work for healthier living environments. But still, in health system, we have some things to do. These are a few recommendations. First, measurement and monitoring on inequality in health and healthcare performance. Second, public health policies that work very well to universally prevent problems and diseases such as tobacco taxation and empower for tobacco control. And of course, the launch of WHC is a necessary condition. And beyond WHC, we have to launch targeted strengthening of healthcare delivery to meet the special needs of people, of disadvantaged people. And also we have to emphasize evidence-based prevention and health promotion for all. These are very important. And taking Taiwan as an example, in 1995, we launched our national health insurance. And before the launch of national health insurance, we saw that life expectancy gain was higher among communities with better health condition. But after the launch of national health insurance, it's the communities with poorer health status which gains higher life expectancy. So the gap is closing. Wonderful, very good. However, regarding diabetes and cancer mortality, these two major diseases, their mortality continues to rise. And the mortality raised more among communities with poorer health conditions. So among these two conditions, the gap was widening. So what did we do? Okay, first, after the UHC, we need to strengthen our health system, targeted strengthening, right? So, for example, for cancer, we strengthen the capacity for cancer diagnosis and the treatment and follow-up and referral in remote areas by collaboration with big tertiary care hospital to strengthen their ability. And also, early detection and screening, we have the outreach screening. For example, for breast cancer screening. And we witnessed the comparable growth in screening rate in 3 levels of community with different levels of resource. So actually the community with lowest level of resource actually gained even higher screening rate than the communities with higher resources. And prevention is important, right? So we increased the taxation on tobacco. And with the increase in taxation, you can see different lines. The highest line is the people with lowest educational level. They have highest smoking rate, but they experienced highest reduction in smoking rate after the increase in taxation. So the gap is again closing on smoking rate. And of course, we want to remove the barrier to stop smoking, so we pay for smoking cessation. And actually, these 4 things are linked together because as many countries, it's difficult to increase the budget of national health insurance. And here, with the increase of tobacco taxation, we generate revenue to support strengthening of health system in remote areas, to pay for cancer screening, and also to pay for smoking cessation. So in this way, we link all these strategic investment to tackle the problem of SDH. And actually also in the field of maternal and child health, we managed to reduce infant mortality rate and to close the gap between different communities. And also we achieved very high and very comparable newborn screening rate in different counties and cities. And for our migrant mothers, for the migrant brides, we pay special attention to them. And it turned out that our migrant mothers had lower percentage of low birth weight than our Taiwanese mothers. So actually, they show even a better birth outcome than the local mothers. And is it time up? Oh, okay. And yeah, so I have some suggestions regarding the health professionals' role. At patient care level, we should emphasize health promotion and prevention for each patient. And we give extra time and support to the disadvantaged patient. And we assess social needs and navigate social resources for these patients. And at practice management level, we monitor, identify, and improve. And we provide active reminding and outreach services to those people with special needs. And we map non-medical resources to work together with medical resources. And at community level, remember to take upstream approach. So you are the expert to advocate for social determinants of health and to enable politicians, show them the right way, the right approach, and to mediate with different departments to implement health and equity in all policies and approach. And so, as an expert, you can be the leader to make changes happen, and we engage the highest level of politicians, show them the data of the inequality, and show them how the politicians might change the situation. And we should institutionalize and structuralize SDH into our public health system. We are happy to see that WHO now has a department of social determinants of health. And also very important, we should engage our future generation. We should include SDH into the education and training of our healthcare professionals. And there is one previous slide regarding the universal promotion and prevention. And you remember the Director General of this region of WHO mentioned the health promoting hospitals. And if you would like to see further details, I have shared my experience regarding how to mainstream health promoting healthcare as the way we transform our care, and we can turn universal health coverage into universal health gains. And last slide is about my contact information. You are welcome to contact me for further details. Thank you.
Thank you very much. Thanks very much. Can I just ask you, how easy do you think, or how much of a battle is it to try and motivate staff working in a hospital with sick people to have a different view about the wider stuff that you've been talking about? How much of a challenge do you think that is? And what's the role, I guess, of leadership within hospitals to do that?
I think it's not easy, but communication needs to start from where the problem is. So quite often when our staff are complaining about inadequate budget, and we talk about the upstream approach. And also, we found that healthcare professionals this morning, we talk about being nice, and and we found that healthcare professionals, they are keen to especially, actually, they are happy to demonstrate their kindness to people, to disadvantaged people and to disadvantaged communities. However, I think we still need to do it in a more organized way. Yeah.
Okay, thank you. And a final point, which I think is a challenge which is often given probably to the whole WHO thing, which is an argument that says prevention will save money and it'll help us control demand and all the rest of it. I mean, the reality is, of course, if people die, they're very cheap. If they live longer, and they live longer and happier and better lives, which we all want, of course, but actually the costs start to go up because the tail of morbidity of the people who will survive is likely to be quite long. So I can remember an argument in the UK which said, if we stop people smoking, it will save the health service billions of pounds. And of course it didn't say, it said millions of lives, really good, but it didn't actually save the health service because of course those people went on to have other conditions, which we may hear about a bit from Bagher later on, such as dementia and all sorts of other things. So how do you, and maybe that view, especially for people who are working in the acute sector, maybe, an argument, if you're saying we will relieve you of stuff, they say, well, it won't relieve us, it just means a different set of people will come along.
First of all, we need to go back to evidence regarding the issue of aging. Actually, there is an article published in New England Journal of Medicine comparing older people with different health status and look at their lifelong spending. And they found that people with the worst health status survived least years, but with the highest total spending. And the people with healthier life status, actually, they live longer, but they spend less.
Okay.
Yeah, but at the same time, the government is spending money in any way, right? So we say, why don't we spend money to get better outcome? So we are spending money, but we spend money to get better outcome instead of seeing the condition continuing to get worse.
Okay, thank you very much indeed. Let's hear from our third speaker, Dr. Bagher Larijani, who's going to talk about chronic conditions.
Good afternoon. I would like to talk about the health services, and we try to talk some words about the current condition with the aging population. As you know, one of the important issues is the global status of aging population is increasing all over the world. And the aging and chronic condition have some relation to issue that we must maybe talk some words about this issue. And the role of the health system in healthy aging is very, very important. And the role of the health system is tied to the chronic condition, and some intervention we try to done in my country, and we talk some issues about this fact. As you know, the aging problem is increasing by the time, and you can see the age other than 60 years is double by the time between 2017 from the period of these to 1980, and is expected to double again by the 2050. And 80% of the older population is live in low and middle income countries. And this is the important issue for health expenditure in this group of the country. And this is very important issue for the management of this. And you can see in this slide the life expectancy is increasing in many of the countries of the world. And it is improving survival to older age have contributed to in the population aging as well. And you can see in this slide between the different period of time some demographic indicators. And you can see the population age other than 60 is about double between 2070 to 2050. And similar to this, the range of the percentage age other than 60. And similar to this, the medium age of the population increasing in many countries of the world. And you can see the situation of this indicator in Iran. And it is a very tight relation between the common health condition associated with the aging with the non-communicable disease and the non-communicable problem. And you can see many of the disease, for example, diabetes, ischemic heart disease, and problem of the chronic obstructive pulmonary disease is increasing by the time and increasing by the non-communicable disease with the chronic condition. And the management of this is very related to the aging group. And you can see some of the risk factor of the non-communicable disease increasing by the elderly population. For example, high blood pressure is the top of the risk factor between the aging group, and it is one of the important risk factor of the non-communicable disease. And we have commitment to action on healthy aging with the National Program for the Care of the Elderly, and this is accepted by the government, and we try to implement in this activity in different universities of the country. We follow the NCD target for Iranian population, and we change some of the target for the aging group and for the population roughly, and we are designing some Iran's specific target for these groups. And it is very important we try to integrate care of the elderly with the chronic condition. The situation of Iran is we have integrated of the education and research and health services. It is very easy. We try to change some of the hospital to follow some of the research and education for this group. But the package of the management is very important because we need this package for the first contact to the patient to the top referral system, the geriatric package, geriatric consultation unit in some hospital, and comprehensive geriatric assessment and the clinic of this group. The integration of the medical education, research, and health services is a very important point for this issue because all of the university and all of the population under supervision of one university. This university have a job for education, research, and health services. And because of this, the responsibility of some educational hospital is management of the healthcare, education, and research in health services. And you can see the trend of the hospital number increasing by the time. We have 1,000 hospitals within the country, and 250 of them is educational hospital. And the management of the hospital is better by the time, and the trend of average length of the hospital stay is come down, and you compare this study with the increasing of the aging, and it means the efficacy and the activity of the hospital is better and followed by the government. The incidence of the hospitalization base of the age group during the previous different months, and you can see if the aging between the aging group that the incidence of the hospitalization is increasing. It is obvious, but it is the rate of the situation. And some of the disease I mentioned, the aging and some of the chronic and non-communicable disease is very tightly tied with each other. And you can see in this slide the rate of the diabetes roughly is 10%. But when going to the 70, over than 70 years, the rate of the diabetes grow to the 22.8%. Similar to this to hypertension. Hypertension is roughly 1/3 of the population have hypertension in the adult group. But when you go into the over than 70 years, it means it's leading to the 63.7%. And similar to this obesity and cancer problem, you can see the cancer problem in the age over than 50 or 60 is increasing. And diabetes, we have a program for some of the chronic disease is tightly linked to the aging problem. This program is holistic program. For example, for diabetes, prevention of the diabetes, registration of the diabetes, management of the diabetes in different level of the hierarchy of the health system. One part of this is outpatient clinic, the other is related to the hospital-based management of this group. And similar to this to the cancer, and we have registration for the cancer for outpatient and in hospital, and development of cancer control program and the screening of this group. Similar to this issue for the cardiovascular management, and some of the management for the cardiovascular is 24/7 days, and this is very important for prevention of the cardiomyopathy and loss of the myocard of some patient. We're going to some of the risk factor relation to the aging group and related to the non-communicable disease. The top risk factor is high blood pressure, and we have a campaign for other than 30 million evaluation of the people for this risk factor, and many of the hospital and out clinic is manage and follow of this group for the screening and recommendation for the management of this group. We follow the guideline of the WHO, and you know Iran is a fast-track country for the management of the non-communicable disease. In conclusion, the aged population is an increased trend in many countries of the world. Chronic condition and multi-morbidity prevalence rise with the population aging, and health services could have a positive role in prevention of the chronic condition and realization of the active of healthy aging. And in case of chronic condition, integrated health system is very, very important to reduce length of stay in the hospital, better management of this group, and increase in the elderly patient satisfaction and the management of this group. Thank you for your attention.
Thank you very much indeed, Bagher. I wonder if I could ask you maybe an obvious question just from that last point. Do you think the interventions that you've described will reduce the number of people who are coming and turning up at your big acute hospitals and your hospitals?
Yes.
And have you got any what does that look like over the
Yes.
next period?
Yeah, we have a very good network of the health. And before the patient coming to the hospital is followed by the nurse people who manage from the small city or small village. And after this group is evaluated by this health person, refer is with the high-risk group, and we have a guideline which person is referred to the second stage, and from second stage referred to the third stage. And many of the patients with the outpatient management is not going to the hospital. 75% of the management is outpatient usually, and some of them is referred to the hospital. And after the hospital, some group is referred to the before the stage, the second or the first. You may be familiar to the Behvars. Behvars is the first contact health primary health to this group, and many of them we published some of the group the article in the Lancet and shows the Behvars manage the diabetes better than for example subspecialty of the endocrinologist. And it means the follow-up of this group, not refer this group to the hospital, not refer to the other clinics, maybe managed by the health system post or some similar to this issue.
Good. Okay, so do use Slido. I think we'll probably put the Slido thing up again. So do fire any questions, or indeed if anybody wants to just ask a question, just head towards the microphone and I will bring you in. Ann-Lise, how far do you, this great thing of universal healthcare 2030, in 2030, if this works and we make significant progress, how different do you think hospitals in particular will be in their view of their role towards that kind of wider concept, which we've heard from other members of the panel about well-being? How much change do you think we'll have?
Well, I think the question should be reversed. It's not if it works, how hospitals will have changed. It's so that it works, how hospital must change. If hospitals don't change, if the health systems in general don't change, we will not get to universal health coverage in 2030. It's not about doing more of the same. It's not doing about better quality of the same. It's not doing cheaper of the same. It's really
all of those, though, are still important, aren't they?
Those are all important. They're all essential. But it is also of thinking about other things we need to do. Yeah. And those other things are linking health and social care, are really also looking at the demand side, are really being embedded into the local communities, both for hospital, for primary care center, for nursing homes, for all the care providers. And I think what will be different, and we will work if we really consider that we are all on the same boat, if we really have aligned our vision together for population health and well-being. And if we find innovative ways to not just get the people to adapt to us, but find ways where we can adapt to the people. A very common question I hear is that, our communities or people, they bypass primary care, they go to hospital. How can we do to respond to this? And there are different ways to respond to this. But the first question is, why do they bypass? Why? Trying to understand the reason why people access care here or there. And I think when we have solved this, then it will be different. I have a very simple example. I visited a center, very small center in China, in a very rural area, remote area, and they had this center and they had 2 washing machines, just 2 washing machines. What it means, those 2 machines were for these elderly people, isolated people. They could come and get their laundry washed because they don't have the strength to go and wash them by hand. But this means that by coming regularly, they knew the healthcare providers, they were also having these social contacts. And it's just about health and well-being and knowing where you can get. For hospitals, this means that they will really view themselves as part of an integrated network. I think we will see less of a typical hospital profile, and I hope we will see much more diversity in what hospital, not in what hospital look in their walls. Indeed, we have seen pictures of different kinds of hospital. We already have this diversity, but a lot of diversity in what hospital actually do, really to adapt to the needs of their population.
Okay, thank you very much indeed. Let's move on to some of these Slido questions. So let's start with, I don't know whether we start at the bottom or the top. Let's start from the top anyway. Thank you for emphasizing the social role of hospitals, but doesn't this just substitute one iconic status for another? I think it'll have to be you, I think, to start off with that. I'll ask the other two as well.
I will be very short because I understand that I don't want to talk too much. I don't think it substitutes. I think we need to recognize it and to build on it. We cannot just say it does not exist. It does exist, so how can we build on this? It's just building on this rather than substituting.
Shu-Ti, what about you?
I wonder whether I get the question correctly. Does it mean that why should we do the role of social sector?
I think it's saying that hospitals have a sort of iconic role at the moment.
They have too much visibility, and we would like
lots of power and all the rest of it. Yeah.
Well, you have patients. You saw patients with, especially people with lower socioeconomic status. They tend to be sicker, right? And when you are treating the patients, somehow they couldn't collaborate. And there are some reasons in addition to your technical skills. So somehow you need to look into those factors so that you can maximize the outcome of your health services. And of course, everyone, including primary care physicians, when they are seeing patients, they have to also look into this aspect. But everyone who have the encounter with the patients need to also look at that aspect too.
I think that point, and you did touch on it a bit on your talk about the role of the health professional in this. The health professionals of 2030, the vast majority of them are already practicing now. So it's only 10 years, it'll happen very quickly and all the rest of it. How much does the mindset, in your view, of health professionals, particularly working in hospitals, but maybe in the healthcare system, how far does it need to change if it's to embrace the agenda that you described? And how do we get that? Because you're not retraining everybody. You might offer them some additional training, but we're not starting from scratch. These people are going to be the same people who are practicing now, will still be practicing in 2030.
Yeah. For healthcare professionals who are already practicing, I think we need to collaborate with professional society, professional associations in their continuous education to introduce this aspect of problems and this aspect of approach so that the problems on our shoulders can be solved together with the broader society altogether. Otherwise, the problems are only on our shoulders. And it's, as I mentioned, we really need to tackle the upstream problems.
Okay, thank you. Let's go on to our next question, which is from the top. What role should the life sciences industries, pharma, medtech, play in developing the effective health systems and managing chronic conditions? Bagher.
I think this is very important. The hospital is not related to the medicine group, means the specialty of the medicine. This is related to all of the specialty, nursing group, pharmacist group, and others. This practice is done this time in Iran, and it is the hospital is moving to the educational hospital. All of the discipline and the different group, for example, pharmacy is for example, clinical pharmacy coming to the round of for the management of the patient, and the drug is in the hospital is managed by this group. The nursing group, the education of the nursing group for the field education, the hospital is service for the education of the nursing and others. I think this is very important. The holistic of the medicine must follow in the educational hospital. And this is very important for the management of the patient. If you, for example, the staff of the pharmacy affair and the pharmacy, for example, branch of the pharmacy, if manage the service to the cancer group, it is very effective than the other practice group in the pharmacy may be involved with. And I think this is very important for all of the patient, and especially for the chronic disease, because the problem and the management of the chronic patient is very difficult than the other groups, roughly. And this is sometimes maybe need coming to the hospital, going, and the education of this group for this patient is very, very effective. And I think this is very important issues.
And do you think that there also needs to be a change? I think there is some change going on ahead, so I guess it's how much, between industry, between pharma and medtech and the healthcare sector. So it's less about, I'll sell you a pill, get on with it. It has to be about, where does that intervention fit in, and how do you reorganize your services, and then you involve all parties in developing that change?
I think this is very important to how we define the job of the different group in the hospital. It is dependent to this. If you, for example, have some responsibility to the group of the pharmacy for education of the patient, yes, it is change. But if not, maybe the situation is not very effective of changing for the different discipline involved with it. But I think roughly the educational hospital, the management of this group is better than the other group. We have the experience of not integration of this group to the hospital, and this time integration in some hospital. The management of this group of the hospital totally changed. And it is the best hospital roughly from the management, from the integration for the difficult cases for the management, chronic disease and others, comparing to the past and comparing to the other place of the country, not have integration of the educational group to this group.
Okay, thank you. Shu-Ti, what's your thought on this?
Yes, we did see some pharmaceutical companies, in addition to innovate new drugs, but also the software or the app to help patient self-management or to help chronic disease management inside of the hospital. I think working together might be one way, but I also agree that sometimes it's difficult to integrate the external management software into the internal condition of hospitals.
I mean, is that not part of the thing that might, again, I'm never quite sure whether 10 years is a short period or a long period, but if you're talking about people empowering patients, then new treatments in which they actually control the treatment themselves, which they have much greater access to, and actually they're much more expert, frankly, than the doctor or the nurse on their own treatment. Is that not likely, again, to speed up all the things you're trying to achieve?
Yeah. Yeah, actually, with the digitalization and many, I think the traditional model of healthcare will be largely changed, because nowadays patients would like to have higher control of their own time. And if they can access the services virtually in the time they are convenient, in the place they are convenient, why not? I think that's quite possible to happen.
Okay, Ann-Lise, respond to that, and then I'll move you on to the next little challenge.
To respond directly to your last question, I think technologies provide huge opportunities. They provide huge opportunities for patient empowerment. But when we introduce any of those technologies, it's important to assess whether everybody will be able to benefit those technologies, or whether those technologies will benefit from to those who are already well educated and well and able to benefit from them. Some are just a way to reach out to the most vulnerable and enable by digital health to get to the people in remote areas. But I think it's not obvious. So this is something we should systematically ask, whether this will help improve equity or decrease equity. When I have the word, because my mind is thinking a bit slowly, I'm tired, I just want to rebound on the other point on, that was the first question and your follow-up question on the role of health professional.
Yeah.
I highlighted when I responded the mindset of the people, the user. The mindset of the professional is essential. And I'd like to give 2 or 3 very different examples. The first one is from Oman. This is our host country. And when I visited the hospital, I was giving so many examples of how they work with the communities, with nurses, rotation of nursing in health centers, with analysis of referral to understand why the patient had come to the hospital when maybe they could be treated in primary health care. And I asked, why do you do all of this? And the answer was so genuine, was because it's our community. And this is really a mindset. And it came as obvious, but I don't think it's obvious everywhere. And I think we need to recognize this mindset. But then I've seen the Changi General Hospital was recipient of an award, and we have also, I've read and heard about really a lot of good story there, so I will cite this hospital by name also. And they have done a number of things with the health professional, reassuring the patient that if they go back to the primary care doctor, there is themselves, they trust the primary care doctor. Themselves, they will answer to the primary doctor in case there is anything going wrong. Why did they do this? Mainly because, I mean, I may be simplifying, but there was a huge congestion in the hospital, a very high occupancy rate, and the only way to be able to continue to survive, to do their job, was to work with the other. So there it was a mindset that was created by a need for survival, for continuation. Yeah. So I think there are different answers depending on the context, but the objective in the end is the same, is to work together for the population health.
Yeah, very interesting. Thank you. Can I just move on to this rather challenging one, the second one down? UHC is overly ambitious. Everything cannot be achieved. What are the key outcomes for 2030? I mean, it's a fair challenge, isn't it?
Yes. It's ambitious, but then I think it's really important to understand UHC right. It's not about giving everything for everybody. It's about the progression. It's how we progress to improve how many people we are able to cover, the type of services we are able to cover, and the quality of services we are able to cover. It's what we call a gradual human rights. What matters is to make some choices that reflect the collective values that are being discussed, and then to be accountable for ensuring implementation of what was collectively agreed. It's not getting, we will always need to do some choices. That's clear. And we don't say we want to deliver everything free to everybody, because health is one of the priorities, you have education, you have a number of other priorities. But really what matters is to continuously progress, to have an ambitious agenda, to be able to go as far as what we can get with our resources.
And do you, either as an organisation or personally, do you have an idea, taking that 2030 point, about what would good look like by then? How much progress would we have made in a relatively short period of time?
I think we can make huge progress. We can make huge progress because a lot of it is not around it. A part of it is indeed, as was highlighted, mobilizing sufficient financial resources. But even with the resources we have, if we fix the system, if we get it right, we can do so many improvements, small scale, that make a major impact. So I think we can definitely improve a lot, but and that it will look very different. We need political commitment. I think we have political commitment now. There is this momentum. We have a strategy with primary health care as the backbone of strong health system. We need to implement it. And so by the implementation part is really not the issue. And it requires really not just having high-level dialogue, but really working with the managers, with the health professionals, with the patient, to really find innovative solutions with the resources we have, and to work together, breaking those silos.
Bagher, you're an optimist on this?
I think maybe the improvement is very good, because many of the countries try to expand the WHC in the healthcare, but maybe in some cases it is encouraging, and some cases maybe not, but I think the improvement is possible in the future.
Okay. And
EMRI has demonstrated that it's possible.
it is possible. What about you, Shu-Ti? You must be an optimist.
Yeah, and I think it has something to do with political determinant of health. And I think we need young generation who can be the activist for the human rights to health and healthcare, to mobilize the society, and to make that political decision happen.
But to be clear, we're also not saying this is just about money. It is about changing the way that we do things. Yeah. Okay, let's have a look at the next question, which is how is it possible to achieve UHC with the increasing cost of therapies, especially pharma? It's a question from Spain. So drug costs are going up. How can we afford it? Ann-Lise.
Well, I will provide a very similar answer. It's really about making choices. Those choices are very difficult. To build those choices, we need evidence. We need cost-effectiveness analysis. This is for sure. But then afterwards, evidence is not enough. It is also about the values, as I said, and getting a consensus around those choices, or as close as we can get to a consensus, and having a societal dialogue around this, so that we understand why and how those choices are being made. So some therapies are very costly but highly effective, and for some there will be indeed some discussions needed, and we see I'm from Belgium. A few months to 3 months ago, we had a case of extremely costly, like there are 3 persons in the whole country, which is a small country, but still, who cannot use these drugs. The Ministry of Health refused to cover it. And then we had, because apparently it's not effective after a few months, and we had this web, those web where you can all give a bit of money.
Oh,
and then
crowdfunding.
Crowdfunding, and in 3 days, the baby who was on all of the newspaper had received her money.
Yeah.
While the other part of the country has a special screening program, so that you identify the baby within their first week, and then this medicine will be effective, and this medicine is so it's really some. It shows that it's difficult. And when you see the picture of the baby, well, you just want to give your money for this little baby. It's not easy. That's definitely, I recognize it, but we need to make it as transparent and as objective as possible, recognizing the underlying values.
And presumably, I don't know at state level, Bagher, but people ought, in any system where society is being expected to pay for these drugs however they're paid for, should have some means by which they test the value before they may be effective but they cost an absolute fortune, or they may be cheap but ineffective. But you've got to make those judgments, haven't you?
I think the universal of the health services not means only expansion, the using of the drug, and it means the management of the patient. Sometimes maybe lifestyle change, sometimes maybe some recommendation. This time, I think in the region, maybe over than 25% of the cost of the hospital is related to the drug. And the management of the patient and the package of the management of the patient is very important. I think it is not equal universal health coverage to the expansion of the using of the drug roughly.
Okay, thank you. Let's go on to our next question, which is, I'm just trying to get this right. A profound transformation of hospital-centered culture to impact our community. SDH is urgently needed. How to reward the adoption of value-based healthcare. Ann-Lise, I'll start with you on that one. It's quite a profound question.
No, there are a number of answers to this. As you have imagined, I always have answers. No, but indeed, one element is, and we have talked a lot, is about mindset, and it will be about education and all of this. One element is about financing. And as long as we are financing hospitals as individual entities, mainly according to volume, while we finance differently primary health care, it will be very difficult to have this integration. As long as a hospital will have to take their very scarce money and in order to go beyond their mission to provide highly specialized services to extend to health promotion, and this will not be rewarded in any way, it will be only based on the individual values and ambition of the managers, of the clinicians. We have seen a number of examples, but it will be really difficult to extend. So in most cases, changes in financing and in governance will be absolutely needed to really go to a different scale, to really go beyond the individual behaviors.
So we have to incentivize hospitals differently to get different behaviors.
I think we have to see that hospitals have different functions. One of the functions is to deliver highly specialized, complex services. And this is to be financed in one way. Can be volume-based, can be fee for performance, and so on. Another another function of the hospital is to support well-functioning health system, to support, their work with the primary, to amplify the effectiveness of primary health care. And this coaching, this mentorship, this sharing some material, sharing some knowledge will be financed different way. You will have different indicators, and often this is not being financed. Then you will have the research and education, which costs and needs to be financed different ways also. So what I mean here is that there is not just one way to pay for performance, to pay hospitals. We need to see their different roles and functions and then adapt the payment system. Then there are some bundled payment across different care providers that are being tested. That is one of the options. But I really think that the financing will look as a mixed system, because each ways has its strengths and weaknesses, and it's by mixing up that it's like the poison. It depends on the quantity you have, and it can have
the dose.
So it's really a question of good dosing. It's really not easy, and it needs to be dynamic.
Thank you. Shu-Ti.
Yeah, I think sometimes there is already hidden reward, but we didn't see. For example, for DRG payment, if you provide smoking cessation before the surgery, actually the complications after surgery can be reduced, and you get reward. But sometimes our hospital managers do not know that, so we have to show the evidence. But still, we also hope that the National Health Insurance, whenever they are facing the cut of budget, or whenever they get extra budget, they use that opportunity. When they are cutting budget, they reserve the cut. They don't cut the payment for prevention and value. Okay, and when they have extra budget, they allocate more on rewarding value-based healthcare. I think there's opportunity to increase more and more investment in this way.
Bagher, what's your view on this?
I think the hospital is one part of the health services, and it not means the central of the health services. One of the important part of the health services. It is very important the team of the hospital have some knowledge about the SDH and something and others, and work with the other part of the health services for follow and changing the situation of the SDH and improving of this. It not means the hospital is the cause core of the health services.
Okay, thank you. Right, let's move on to, I've got 3 more questions and 5 minutes to go through them, so there's the challenge. How do you break the downward spiral of interaction of health unfavorable factors such as poverty, food, education? How do you solve all the, it's called boiling the ocean, I think, with health and all policies. We've touched actually on a bit of this, but I mean, I guess, and I answer the question as written rather than how I rephrase it, but there obviously is a reaction which you get from people within the healthcare system, which is, I know all these things affect health, I can do these interventions, I can only do this, how do you expect me to solve all the world's problems? I don't know if that is actually behind the question, so interpret the question how you will. Start with you, Shu-Ti.
Yeah, yes, but as I say, we can serve as the advocator, as the enabler and the mediator, so that we direct decision makers towards those upstream interventions which will benefit all and save some healthcare costs. Yeah, I think that's still important because in my situation, I found it's very difficult that whenever healthcare professionals were asked about how to improve population health, their answer is, we will do more health education, we will provide more services. However, it's very labor intensive and it's not the best buys. So in this morning, you have all the packages of best buys. Remember that and bring those best buys back to your countries.
Excellent. Bagher. Okay. Louise, do you want to add to that?
No, I fully, first is to be, you say, I know, well, between knowing and being convincing and having a change in behavior, there is some margin. So first, really the awareness, it's still need to be strengthened in a number of cases. And then indeed, you cannot do everything, but being part of the table. If we refer this to hospital-based professionals and managers, they can raise the awareness, but also if they are being called, work together with, what I mean is that they should not always convene because they are indeed only one part and an important part, but they should be ready to step in and to help. And if they identify a need to call for this, we had the other example from Oman about sickle cell disease with a number of patients, and you can continue to treat them, or you can go in the community and try to understand and affect. Doesn't mean you will do everything, but at least you will raise the awareness and get a number of people around the table to see how we can prevent and go tackle the cultural, in that case, cultural and other determinants of health also.
So I remember some years ago, a cancer specialist at, I think it was Cambridge University, said if he had spent as much time thinking about where the women, he was a breast cancer specialist, where the women had come from to his clinic, as opposed to looking down a microscope, and he had made advances, significant ones. He thought he would have achieved more in his career. So maybe that kind of, it's that mentality we need a bit more of. Okay, in your opinion, what role will precision medicine play, if any, in UHC plans and population health at large?
Can I answer? I don't know.
please no, do.
I'm not really knowledgeable about this. What I just know is that I will participate in a month's time or 2 months' time to a workshop on precision public health. So now moving from precision medicine to precision public health. But I have read quickly the concept note, and I will not be able to respond to questions around this, but I think the idea and the concept is appealing to me. That's all I can say for now.
Okay. Bagher.
I think the precision medicine is the idea. Some cases and the other cases may be different to each other, to respond to the disease and to selected treatment for this case. I think this concept is very important because sometimes in the hierarchy, maybe you recommend some drug, for example, propranolol. Some cases with 10 milligram may be effective and the other maybe with 100 milligram may be effective. This is one part. The other part, the system of the health services must have some place to evaluation of some cases. For example, the cancer treatment with the precision making, the mortality is changed. And if you best selection for the treatment may be very effective and the side effect is very low, very low. The concept of the precision medicine is a traditional idea from the past. And this time the meaning may be changed. I think this is very important. The health services team have this concept and some place of the medicine, the hierarchy is focused to diagnosis, management, and research in the precision medicine.
Okay, I'm going to try and squeeze in the last question very, very quickly, if they can show it back up again, or if they removed it already. Okay, you've got really a sentence each, and I haven't read the question yet. Do you believe building team competencies that, allied with the universal coverage pledge in the pre-graduation phase, would improve hospital indicators? So team competencies when people are training to be doctor, nurse, physiotherapist, or whatever. How important is that? Ann-Lise.
Essential.
One word.
It will help, but you have to continue the track all the way, not only before they enter the hospitals or healthcare system, but also when they are in the system, we still have to continue the efforts.
Okay. And Bagher.
I think this is very important because if you wanted to go into the universal health coverage, if the concept of the SDH and other, it is very important we educated the team of the health services, educated of the student in the medicine and the other groups. This is very important. We integrated some of this idea in the education of the medicine. And I think this is very effective because the team building must start before the graduation of the university.
Okay, I just want to finish by thanking my amazing panel for some fantastic insights. In some ways, all this stuff is very exciting. On the other hand, I have to say it's hugely challenging. What we're expecting of our system over the next 10 years, if we are to try and fulfill these ambitions, is about how do we train our staff? How do we continually train our staff? How do we change attitudes about with the business that we're in, that is not just about what's immediately in front of me, but what are the causal factors which lead to that, and how do we influence? Probably the issue we haven't touched on, my fault, is how do we engage with the wider public around all this? How do you actually, because that's both about their use of the service, but also their commitment, both in terms of their own individual behaviour, but also as a society, the kind of things that they're campaigning forward.
Can I have one quick comment?
You can have a comment if it's 30 seconds.
No, one sentence.
Oh, one sentence, yeah, okay.
Yes, I'm representing WHO. WHO has developed a curriculum on UHC for medical students that will be, at least for our region, that will be embedded. It's a very short course, but will be embedded in the curriculum of all medical students if the countries endorse it. Okay. So we are working to conceptualize UHC for medical students and other students in the region, Eastern Mediterranean region. Thank you. Excellent.
I think that's a great idea. As a former medical regulator, convincing all the medical regulators in the world would be fun, and indeed the medical schools. But I think that's very good. And maybe you could just send the link into IHF, and we can see that if people want to get hold of it, they'll be able to do so. Okay, I'm going to wind up now. Thank you all very much indeed. Thank to Bagher, to Shu-Ti, and to Ann-Lise for their contribution. Thank you.